Welcome back, guys. In part 3 of this video, let's discuss about the management of preeclampsia and eclampsia. Guys, in part 2, we have seen the pathogenesis, how exactly the pregnancy-induced hypertension or preeclampsia or eclampsia, how actually it happens. We have seen the pathogenesis. Now, after seeing the pathogenesis, let's see a few important direct singular kind of questions. Okay. Now, please concentrate here. First phase of remodeling begins by. Guys, I just want you to know that the vascular remodeling happens in two phases. Okay, we have already seen that there is this trophoblastic invasion. Because of the abnormality in trophoblastic invasion, the female is going to develop the pregnancy-induced hypertension. But the important point which I want you to know is this invasion process, this remodeling process happens in two phases. First phase of remodeling is going to happen in decidua basalis. Okay, in the decidua, this remodeling process is happening. Okay, so that's the first phase. So usually first phase happen before 12 weeks. Okay, so first phase happens before 12 weeks, and the second phase of remodeling, which is happening deep, okay, in deep spiral arterioles in the myometrial layer. Now the second phase of remodeling is happening between 12 to 16 weeks. Okay, these are the direct singular kind of MCQs. Now, test to predict pregnancy-induced hypertension. Guys, we have seen certain factors which are present in the blood. Like, we have already seen that anti-angiogenic factors are going to be elevated, angiogenic factors are going to be decreased, vasodilators are going to go down, vasoconstrictors are going to be elevated. So, there are also the predictors for pregnancy-induced hypertension. But here I am asking the radiological test which can predict that a female most likely to end up in preeclampsia. See, that's the uterine artery Doppler. Okay, so uterine artery Doppler, it's a test to predict the pregnancy-induced hypertension. What actually we see in uterine artery Doppler is this diastolic notch. Guys, whatever you are seeing the notch over here, that's the diastolic notch. Usually this diastolic notch presents physiologically, okay, in a normal healthy pregnancy, this diastolic notch presents, but this notch is going to disappear by 24 weeks. Okay, it's usually present between 22 to 24 weeks. But if this notch persists even after 24 weeks, then we will predict that this female is most likely to end up in preeclampsia. Okay, so important point is that this diastolic notch is going to be normally present between 22 to 24 weeks of pregnancy. But even if it's present, still persists even after 24 weeks, then we can predict that this female is most likely to end up in pregnancy-induced hypertension. Now, definitive management. Guys, this is a very important MCQ. See, this preeclampsia, eclampsia, HELLP syndrome, whatever. See, all these are because of placental abnormality, placental pathology. Now, this placenta is producing the inflammatory mediators, and those inflammatory mediators are acting on the endothelium, and endothelium is getting damaged. That leads to leakiness of the vessels, that leads to thrombosis of the vessels, placental insufficiency, and all the stuff. Now, if all this is because of placenta, if we can remove the placenta, then everything is going to settle down. So what I want you to remember is that the definitive management for treatment of preeclampsia or eclampsia or HELLP syndrome, definitive management is one single thing, that is termination of pregnancy. So termination of pregnancy is the definitive management. See, there are non-specific managements for, you can treat the hypertension, you can treat the convulsions, you can treat the HELLP syndrome by using antihypertensives, anticonvulsants. But what I am talking here is it's a definitive management. See, non-specifically we can manage the hypertension and convulsions, but definitive management, very important MCQ, it is a termination of pregnancy. Okay, it's the same for preeclampsia, eclampsia, and also for HELLP syndrome. The definitive management, very, very important MCQ, it's termination of pregnancy. And what's the mode of delivery? Yes, we are saying it's a termination of pregnancy. So, how we are going to deliver? Is it by C-section or normal vaginal delivery? There is this female who is having preeclampsia. Are we going to jump and do a C-section? Eclampsia patient, are we going to jump and do this C-section? Usually no. Okay, we are going to prefer vaginal delivery. Okay, vaginal delivery is the preferred mode of delivery in preeclampsia or eclampsia. Okay, now important point is that we say termination of pregnancy is the definitive management. But when we are going to terminate the pregnancy, when, for example, there is this female who is having a mild preeclampsia. Okay, we know what exactly is the mild preeclampsia. We have seen the definitions. Now, if there is mild preeclampsia, nothing to be worried. Okay, but there is no end organ damage, so not a big deal. So usually we can wait till 37 weeks. Okay, normal term. So by more than or equal to 37 weeks, we can do the termination of pregnancy. But if there is severe preeclampsia, we know that severe preeclampsia is a complication, okay, or I can say that severe preeclampsia can lead to HELLP syndrome, or the severe preeclampsia can land up into eclampsia. So it's a very dangerous condition. So what we are going to do is, we just want the fetal lungs to mature. We know that it's going to happen by 34 weeks. So we are going to wait by 34 weeks. So once she attains 34 weeks, after that we can deliver the baby, we can terminate the pregnancy. And what is the mode of delivery? Vaginal delivery. So if there is severe preeclamptic patient, okay, severe preeclamptic patient, now she is showing the signs, like, you know, she will end up in the, like, eclampsia, that is impending eclampsia. Okay, now listen my point. If there is the sign of impending eclampsia, then you are going to immediately do the termination of pregnancy. Okay, impending eclampsia, or if there is eclampsia, now she is throwing the seizures. So eclampsia patient, or if she is developing HELLP syndrome, or if there is a placental abruption, we know that in severe preeclampsia there can be placental abruption. So in all these conditions, in all these last 4 conditions, we have to do the immediate termination of pregnancy. Okay, very important point. If there is eclampsia, immediate termination of pregnancy. Okay, so now she came to the department, now she is throwing the seizures. So what you can do? Now what you can do is, you can give the steroids. Okay, you can wait for some time and immediately do the termination of pregnancy. So in impending eclampsia, HELLP syndrome and placental abruption, the best answer is immediate termination. Okay, regardless of whatever is the period of gestation. It doesn't matter whatever is the gestational age, you have to terminate the pregnancy. Okay, give steroids, do the termination of pregnancy. Okay, otherwise, like, you know, it can be very much problem to the mother. Okay, by keeping, like, you know, mother as an interest, we are going to, we just want to save the mother's lives. So immediately we have to terminate the pregnancy. Now after this, let's talk about the hypertension management. We know that definitive management is going to be the termination of pregnancy, and we know when we have to terminate. If it is severe preeclampsia, after 34 weeks. If it is mild preeclampsia, you can wait till 37 weeks. And eclampsia, HELLP syndrome, or is it because of impending eclampsia or placental abruption, we know that we are going to do the immediate termination. Okay, now let's see the non-specific management, that is hypertension management. Now there is this female who is in your clinic. Now she is having high BP. So you have to control her BP. So you have to give her antihypertensive drugs. So what are the antihypertensive drugs which are safely given in the pregnancy? Which means there are certain antihypertensive drugs which should never be given in the pregnancy. There are certain contraindications. Okay, though they are antihypertensive drugs, you are not supposed to give. So what are they? Now we will see. Now these are the drugs which can be safely given. See, the wonder drug, the super important drug is the labetalol. It's a beta blocker. Okay, so labetalol, it can be given orally or it can be given sometimes IV. So when it will be given orally and when it will be given IV, we will discuss. See, whenever there is acute hypertensive crisis means a BP more than 160/110. Okay, BP more than or equal to 160/110. Now that's the acute hypertensive crisis. In acute hypertensive crisis, you are going to give IV labetalol. If the BP is somewhere around 150/100, then you can give normal oral labetalol. Okay, so labetalol is a very important drug, and labetalol is a drug of choice for pregnancy-induced hypertension. It's a drug of choice for many other conditions also. We will discuss in the same slide. Now, labetalol can be given hydralazine, nifedipine, alpha-methyl dopa, nitroglycerin and sodium nitroprusside. all these drugs can be safely given. Now please concentrate here. Now I just intentionally kept this, like the tick marks small in size. Why? Why? Because see, this methyl dopa is something very important for your exams. Methyl dopa, it's a mildest antihypertensive drug. Okay, mildest antihypertensive drug. So this is not helpful in acute hypertensive crisis. So in acute hypertensive crisis, alpha methyl dopa is not helpful. The rest of the drugs are helpful in the acute hypertensive crisis. Very important point, guys. Acute hypertensive crisis means more than 160/110. All of these drugs can also be used in a normal hypertensive female and also in acute hypertensive crisis. But which of the following drugs is not useful in acute hypertensive crisis? It's the alpha methyl dopa. It's a mildest antihypertensive drug. So it is also the safest antihypertensive drug in the pregnancy MCQ. Okay. Now after that, let's talk about the sodium nitroprusside. Usually we don't use sodium nitroprusside. Okay, sodium nitroprusside usually we won't use it in the pregnancy. But in refractory hypertension, okay, you are using all kinds of drugs, but the hypertensive is not getting settled down. So in refractory cases, so in refractory hypertension, you are going to use sodium nitroprusside. So if they ask you drug of choice for refractory hypertension, then your answer will be sodium nitroprusside. One important point about the sodium nitroprusside, it is associated with the cyanide toxicity. Okay, it's associated with cyanide toxicity. Okay, so which of the following antihypertensive drugs is associated with cyanide toxicity? It is sodium nitroprusside. So these are the antihypertensives which are safely used. Now, after saying this, see, let me ask you one thing. For controlling hypertension, if there is a normal female who came to you, and if you just want to control hypertension, are we supposed to use diuretics or not? In a normal female, yes, we can use diuretics. But in pregnancy, that too, now this female is having preeclampsia. Now, are we supposed to use diuretics? Never. I have repeated this many times. See, diuretics should never be used in a hypertensive female during pregnancy, especially if she is having, a preeclampsia and all the stuff. Why? Because already if she is having preeclampsia, there is this hemoconcentration happening. See, again, if you give these diuretics, most of the fluid components will be going out of the body. You are removing the urine, means you are taking out the blood volume. So again, hemoconcentration can occur that can cause very lethal effects to the mother. So these are the antihypertensive drugs which should never be used in the pregnancy. The one important thing which you should never miss is the diuretics. So apart from diuretics, diazoxide, losartan, beta blockers and ACE inhibitors should also never be used. Okay, you can ask me, see, beta blockers are contraindicated, but except labetalol. Labetalol is also a beta blocker, but that's the only exception. Okay, except labetalol, you should not use any other beta blocker. So beta blockers are contraindicated, ACE inhibitors are contraindicated. Why? Because they are teratogenic drugs. Okay, and losartan is a angiotensin receptor blocker, and diuretics and diazoxide. Okay, not diazoxin, diazoxide. These are the antihypertensives which are not supposed to be used. Now after this, let's talk a few important points about the labetalol. Okay, now labetalol, I have already said you that it's a drug of choice for pregnancy-induced hypertension or preeclampsia. It's a drug of choice for acute hypertensive crisis. Okay, so acute hypertensive crisis means BP more than 160/110. Just single episode is enough. So chronic hypertension in pregnancy, we all know what exactly is chronic hypertension in pregnancy. Chronic hypertension in pregnancy means already a hypertensive female, now she got conceived. So for treating chronic hypertension in pregnancy also, it's a one drug, that's a labetalol. Okay, labetalol, usually we use labetalol orally, but in acute hypertensive crisis, we are going to use it in IV form. Now, how much we are going to use this labetalol? Okay, there is this female, now she is having a BP. Now, for example, weight, now she is having more than 160/110. Now, we know that IV labetalol is a drug of choice. Now, how much I should give? See, we have to start with the 20 milligram. Now, she is not coming down, her BP is not coming down. You can go to 40 mg, later 80 mg, next 80 mg. So maximum of 220 milligrams. Okay, this is a very important MCQ. Maximum dose of labetalol is 220 milligrams. Maximum dose is 220 milligrams. We are going to start with the 20 milligrams. We are going to give it 40, next 80, next 80. So still if it's not coming down, we will choose other alternatives. So maximum dose of labetalol is 220 milligrams. Very important MCQ. Now after this, let's talk about acute hypertensive crisis. I have already said you, in acute hypertensive crisis, you are going to use labetalol in IV format, not oral format. Okay. Now let's talk about management of eclampsia. Okay, management of seizures, management of these convulsions. We know how to manage the BP. So all the antihypertensive drugs we have seen. The main important drug IV labetalol or oral labetalol, we have seen that. Now how we are going to manage the eclampsia? Now eclampsia management, the definitive management, I have already said you, terminate the pregnancy. All these problems is because of the placenta and pregnancy. So terminate the pregnancy, everything is going to settle down. So definitive management is termination of pregnancy. See, this is a very important question, very important, like question in your exam. They will ask you, there is this eclamptic patient who is throwing seizures. Now she is in your department. What is the first step? Okay, according to MAGPIE trail means magnesium sulfate for prevention of eclampsia. See, whenever a female is having seizures, okay, most of you guys will rush and think and say that, okay, give MgSO4. So first step in a female who is throwing seizures is MgSO4. No, it's not. The first step is secure the airway. This is the answer. Okay, so securing the airway is the first step in managing a patient with eclampsia, followed by giving MgSO4, magnesium sulfate. Okay, so this magnesium sulfate, why we are giving? For treating the convulsions. First airway management, followed by MgSO4. See, if she is having eclampsia, what exactly is eclampsia? Eclampsia is nothing but preeclampsia plus seizures. So you have treated the seizures by giving MgSO4, but you also have to treat the preeclampsia, nothing but hypertension. So after giving MgSO4, same thing, you can give IV labetalol. So eclampsia management is what? MgSO4, first airway management, okay, securing the airway, followed by MgSO4, followed by antihypertensives, that is IV labetalol. Okay, the same management is also for the HELLP syndrome. If a female is having HELLP syndrome, the definitive management is what? It's the termination of pregnancy. Okay, so you will be giving MgSO4 and also you will be giving same antihypertensive drug, same there also, okay, same treatment. Now, after saying this, let's talk a few important points about eclampsia. There are three, a female can throw seizures 3 times: before delivery, during delivery, after delivery. Okay. Now, let's talk about antepartum eclampsia. Okay, very important MCQ. Antepartum eclampsia means seizures happening before delivery. Okay. Now, she is not in labor. Before labor, now she is having seizures. That is antepartum eclampsia, which is most common. Very important MCQ. Antepartum eclampsia is most common and having worst prognosis. Okay, worst prognosis. This is bad. Antepartum seizures are bad. Antepartum seizures are bad. Okay. Now, what exactly is postpartum eclampsia? In the name itself, it's very clear. Self-explanatory name. Postpartum means after delivery. Okay, after delivery. Now she is having the seizure. Now she is throwing the seizures. But after delivery, how much time? After delivery, 1 week. Okay. See, now she have delivered. After 1 week, if she is throwing seizures, that is postpartum eclampsia? No. So after delivery, within 48 hours, MCQ. Okay, MCQ. After delivery, within 48 hours, if she is throwing seizures, that is postpartum eclampsia. Okay. So this is the management of eclampsia. MgSO4 should be given. How MgSO4 should be given? What is the mechanism of action of MgSO4? In the next slide, we will discuss. Okay. Now this is a magnesium sulfate. Okay, MagSulf. Now let's talk about the mechanism of actions of MgSO4. Okay, mechanism of action. See, this MgSO4 is having a lot of mechanisms of action. One important action is, okay, in the central nervous system, it blocks NMDA receptors in central nervous system. Magnesium sulfate acts centrally. blocks the NMDA receptors. Okay, so well and good. Now it inhibits the release of calcium. Okay, it inhibits the it inhibits the influx of calcium into the neurons. It doesn't allow, MGSO4 doesn't allow calcium to enter into neurons, so inhibits calcium influx. And MGSO4 is a neuroprotector drug. Yes. Why? Because this MGSO4 causes cerebral vasodilation, MCQ. See, why we are using MGSO4 for treating seizures? See, you might have this doubt. For treating convulsions, we are using MGSO4. Why we are using MGSO4? See, first of all, you should know that these eclampsia or the seizures are because of cerebral hypoxia. Now, cerebral hypoxia is the one which is leading to eclampsia. Now, to treat this eclampsia, what you have to do? You have to give the proper amount of blood supply to the central nervous system. Yes. See, this MGSO4, what it will do is, it will cause cerebral vasodilation so that a good amount of blood is going to the central nervous system. So, automatically hypoxic conditions are gone. So, there are no seizures. So, that's a very important mechanism. It's a neuroprotective drug. It's causing cerebral vasodilation, and this magnesium sulfate is also a membrane stabilizer. See, why I'm saying all this stuff is because they will ask you all of the following are the mechanism of action of magnesium sulfate. So you should know. Okay, and this MGSO4 also decreases the release of a glutamate. Glutamate is a excitatory neurotransmitter. There are more amount of excitatory neurotransmitters that can cause seizures. Okay, seizures is nothing but abnormal electrical activity, right? So we have to decrease the amount of excitatory neurotransmitters. So MGSO4 does that. Okay, MGSO4 decreases the release of glutamate, and MGSO4 also decreases motor end plate sensitivity to acetylcholine, MCQ. Okay, now MGSO4 decreases the motor end plate sensitivity to the acetylcholine. All of them are the mechanism of actions of MGSO4. But have I ever said you that MGSO4 is an anti-epileptic drug? See, MGSO4 is not an anti-epileptic drug. See, how it is going to treat the seizures, the mechanism of action is completely different. It's by causing cerebral vasodilation, it's by blocking NMDA receptors, it is preventing the seizures. But it is not an anti-epileptic drug. Okay, very, very important MCQ. This MGSO4 is not an anti-epileptic drug, and it is not an antihypertensive drug. Okay, and where we are going to use it? You are going to use it for treatment of seizures. Also, you can prevent the seizures. So it is used therapeutically, and it can also be used prophylactically. Okay, for preventing eclampsia and for treating eclampsia, you can use MGSO4. And even in the cases of impending eclampsia means eclampsia is going to happen. So you have to prevent, right? So MGSO4 can be given in the conditions of impending eclampsia. MGSO4 can be given in HELLP syndrome also. So very, very important point, the uses are severe preeclampsia, impending eclampsia or eclampsia, and HELLP syndrome. On all these conditions, MGSO4 can be used. Okay, so these are some important points about magnesium sulfate. Now let's see how we are going to use the magnesium sulfate. That's a Pritchard's regime. We know whenever this female who is having eclampsia, whenever there is a female with eclampsia, we have to immediately terminate the pregnancy. Okay, now she is having eclampsia. First of all, we have to stop the seizures. Later, we are going to terminate the pregnancy. So how we are going to give the MGSO4? How much amount of MGSO4 should be given? How to be given? Okay, are we going to use it orally? Are we going to use it intramuscularly, intravenously? Which route? It's an injection, right? So we are going to use IV and IM basis. So how we are going to use the MGSO4, that we will discuss under Pritchard's regime. See how MGSO4 is given. Like, you know, there is this Pritchard's regime, Zussman's regime, Seebein regime. There are many regimes, but for exams, Pritchard's regime is good enough. Okay, so Pritchard's regime. Now, how much amount of loading dose should be given? Okay, I'm going to give 14 grams of MGSO4. Okay, I'm going to take a 14 grams of MGSO4 and I'm going to give it directly IV. No. See, out of this 14 grams, I'm going to split it. I'm going to split it into 4 grams IV. Okay, 4 grams I'm going to give it as IV format. Okay, slowly like you have to give almost 5 minutes slowly. So 4 grams given IV in the form of 20% solution. Okay, in the 14 grams I have separated 4 grams. Now this 4 grams is given as IV 20% solution. Now, so if 4 grams is gone means how much is left? 10 grams is there. Now this 10 grams I am going to split it into 5 plus 5. Okay, 5 grams plus 5 grams I am going to give to one buttock, right buttock and left buttocks. Okay, alternate buttocks I am going to give. So 10 grams in the form of IM, 4 grams IV. Now IV solution is 20%. Okay, more diluted. 20% means it's very much diluted. Now I'm going to give it buttocks, but in the form of 50% solution. Now what is this? See, why I'm so specific? Why? Because see, this drug, okay, MGSO4, it's also a calcium channel blocker. We have seen it prevents the influx of calcium into the neurons. So it's a calcium channel blocker. Now if I am using a concentrated form of MGSO4 directly IV, that can cause cardiac arrest. See, that's the reason why I have kept a small heart over here. Okay, now please concentrate here also. See, this MgSO4, magnesium sulfate, now it can be used IM and in IV form, both, you can use both. But please concentrate here, must be diluted before IV use. If you are using IV, you have to dilute it. Actually, it is available in 50% solution form. Okay, MgSO4 is available in 50% solution form. But you have to dilute it to 20% solution form so that cardiac arrest won't happen. Why? Because this is a calcium channel blocker. So while you are giving IV, dilute it to 20% and give IV. Okay, so that's a very important point. And IM you can give 50% solution. Okay, 50% directly you can give this. Okay, 5 plus 5. Now this is the loading dose of 14 gram. And what is the maintenance dose? You have to maintain the dose, right? So maintenance dose is a 5 gram. Okay, 5 gram MgSO4, same 50% solution. Like for every 4 hours. Okay, for every 4 hours you have to give this 5 grams. Okay, 5 grams of MgSO4 every 4 hourly. So for how much time you have to give? See, from the occurrence of last seizures, next 24 hours you have to continuously give this MgSO4 every 4 hourly. After loading dose, every 4 hourly you have to continue this MgSO4. Or now she is having eclampsia, now you have give MgSO4, now her seizures are gone, now you have done the you are going to terminate the pregnancy. Now after delivery, okay, after delivery, if you have done the delivery or last seizures, you have to give after 24 hours, means 24 hours after last seizure. Last seizure happened 24 hours back. Now till now you have to keep me or keep that female on MgSO4. Okay, after delivery, for 24 hours you have to keep on MgSO4. Okay, this is the maintenance. Loading dose is 14 grams, maintenance dose is 5 grams. Loading dose in two forms, 4 grams IV and 10 grams for alternate buttocks, 5 grams plus 5 grams to the right and left buttock, and maintenance dose 5 grams every 4 hourly for the alternate buttocks. Now you see, after giving loading dose you have waited for 4 hours. Now you are giving the maintenance dose. Now for the first time you are giving to the right buttock, next maintenance dose should be given to the left buttock. Okay, after 4 hours again right buttock, left buttock, something like that. Okay, alternatively you have to give the maintenance dose. Now let's see some few important points. Guys, this MgSO4, it's a very much dangerous drug. Why? Because its therapeutic index is very much low. It's having a very low therapeutic index, which means if you increase the plasma concentration of this drug a little bit more, that can cause toxicity, MgSO4 toxicity. So how much is normal and how much is a female is going to not throw any complications? How much of this MgSO4 plasma concentration is okay, good? See, the therapeutic range is 4 to 7 milliequivalents per liter MCQ. The therapeutic range of MgSO4 is 4 to 7 milliequivalents or 2 to 3.5 millimoles per liter. See, millimoles is exactly half of the milliequivalents. Okay, if this is 4, this is 2, half. If this is 7, this is 3.5, half. Okay, So this is the narrow therapeutic drug. Okay, now let's talk about the MgSO4 toxicity. Okay, and even before giving maintenance dose, guys, one important thing, we know this drug is a very much dangerous drug. Simple increase in the plasma concentration can cause toxicity. Now, important question is, before giving the maintenance dose, we have know that every 4 hourly we have to give the maintenance dose. Now, before giving maintenance dose, we should be pretty much sure that there is no toxicity has happened because of MgSO4. So what we should check? We should check certain parameters. What are they? Guys, before giving the maintenance dose, always make sure that MgSO4 toxicity is not going on in the body. Okay, so what you should check? You should check the patellar reflex. Actually, there is no MgSO4 toxicity means patellar reflex will be normal. Which means if there is MgSO4 toxicity happening means patellar reflex will be gone. Okay, so always before giving the maintenance dose of 5 milligrams of MgSO4, always check these parameters. What are they? Check patellar reflex and it should be present. Okay, and urine output should be more than 30 ml per hour. Okay, at least 30 ml per hour should be there. Why? Because if urine output is not happening, okay, if urine output is not happening more than 30 ml per hour, which means kidneys have some problems, kidneys are failing. If kidneys are failing, MgSO4 is not coming out of the body. If MgSO4 is not coming out of the body, it is staying inside the body and it can lead to toxicity. It should be coming, it should be getting metabolized and it should be excreting out of the body. If urine output is not good, then MgSO4 toxicity can happen. So before giving the maintenance dose, always check the urinary output and respiratory rate should be 12 beats per minute. Okay, at least or more than or equal to 12 beats per minute, and saturation of oxygen should be more than 96. If any one of them is not present or abnormal, then don't give the MgSO4. Okay, don't give the maintenance dose. Why? Because magnesium toxicity is happening in the body. If already magnesium toxicity is happening in the body, if you give again MgSO4 maintenance dose, that's crazy, that's mad. Okay, so what are the signs? What are the signs of MgSO4 toxicity? See, if there is no MgSO4 toxicity, patellar reflex will be there. Now, loss of patellar reflex is the first sign, MCQ. Okay, so loss of patellar reflex is the first sign of MgSO4 toxicity. And at what plasma concentration patellar reflex is going to be lost? If plasma concentration is reaching more than 10 milliequivalents per liter, more than or equal to 10 milliequivalents per liter, then patellar reflex is gone. Okay, it's gone. What is the normal therapeutic range? Normal therapeutic range is 4 to 7 milliequivalents per liter. But if it's getting more than 10, patellar reflex is gone. If the plasma concentration, if it's getting more than 12 milliequivalents per liter, then there will be respiratory depression. If it's more than 15 milliequivalents per liter, then respiratory arrest can happen. And if it's more than 30 milliequivalents per liter, MCQ, cardiac arrest will happen. Cardiac arrest will happen. Now, these are very much dangerous, like low therapeutic index, narrow therapeutic index drug. Now, there is this female. Now she is throwing the seizures. Now she is having eclampsia. Now you know what to do. You followed the Preechart's regimen. You have given the MgSO4. Now before giving maintenance dose, you have checked for all these parameters. Now these parameters are abnormal. Now you know that in her MgSO4 toxicity is happening. Now what to do? If there is MgSO4 toxicity is happening in her body, what to do? What is the antidote? The antidote for MgSO4 toxicity is a calcium gluconate. Okay, the antidote for MgSO4 toxicity. Okay, antidote for MgSO4 toxicity. Okay, it's a calcium gluconate. You are giving the calcium. Why? Why? Because this is a calcium channel blocker. This MgSO4 is a calcium channel blocker. It's not allowing the calcium to go into the tissues. Okay, so that cardiac arrest can happen. So you are rapidly giving the calcium supplementation in the form of calcium gluconate. Okay, 10 ml. Okay, 10 ml IV you are going to give. 10 ml, 10% solution. Okay, 10 ml, see here. So 10 ml, 10% solution of calcium gluconate is a antidote of choice for MgSO4 toxicity. And in which patients, in which females, you should never use MgSO4. See, this MgSO4 is absolutely contraindicated in renal failure. We know if kidneys are failed, MgSO4 is not going to come out. If you give her MgSO4, if you give her MgSO4 via Preechart's regimen, MgSO4 is going to stay in the body. That can cause MgSO4 toxicity. That can kill the patient. That can cause cardiac arrest and respiratory arrest. Okay, and also in myasthenia gravis. Okay, myasthenia gravis patient, he is not able to contract the muscles properly. Okay, already he is not able to contract. If you give this MgSO4, it's a calcium channel blocker. So calcium is very much important for the muscles to contract. Okay, so in a myasthenia gravis patient and a female with a renal failure, MgSO4 is absolutely contraindicated. Okay, now, okay sir, well and good. Okay, now let's talk about, there is this female. Okay, now she came to your clinic with eclampsia. Now she is throwing the seizures. Now you very well know that now she is having eclampsia and how you have to treat it via MgSO4. Now you are giving the MgSO4, but her seizures are not getting normal. Now she is, even after giving MgSO4, she is repeatedly throwing seizures. That is status eclampticus. Okay, very fastly, like she is throwing the seizures. Now now there is a seizures immediately. Now again she is throwing a seizure. Like now if she is having such a condition, we are going to call it as status eclampticus. Now for treating status eclampticus, we are not using MgSO4. We are going to use thiopentone sodium. So thiopentone sodium is the drug of choice for status eclampticus. Okay guys, I have discussed all the important points regarding pregnancy-induced hypertension. I have discussed about the pathophysiology, risk factors, management and everything. Hope the video is helpful. Thank you.